We are going to start a new session in our liver imaging lecture series, and today we have our esteemed colleague, Dr. Richard Du. Dr. Richard Du is an associate attending physician in the body imaging service in the Department of Radiology at Memorial Sloan Kettering. It's my pleasure to introduce him. Very nice colleague, as many of our LI-RADS members. And, really a lot of the credit goes to him for developing the treatment response algorithm. So he's the former chair of the ACR LI-RADS treatment response working group, and his research interests focus on the hepatopancreaticobiliary malignancies and particularly treatment response. And he is the principal investigator for NIH grant on prognostic radiomic markers for colorectal liver metastases. And I was hoping that I speak more on Dr. Du because he has a lot more to say, but I wanted to just shorten this part. And, he's a very nice guy, very nice colleague, and very hardworking, energetic.
So, as advertised, I'll talk about treatment response, and I'll talk more about the concepts behind treatment response and how that guided the response working group to develop the LI-RADS treatment response algorithm. Tomorrow, Dr. Mandarita Lala will talk more about case examples and applications to local regional therapies. But today, let's talk about the concepts behind it. A few disclosures. Let's start with this case. How should we measure this patient's response after therapy? Prior to treatment, you see on the arterial phase a very large right-sided tumor that extends over to the left hepatic lobe. And after one round of embolization, there's clearly some response. Less of the tumor is enhancing, but the anterior portion of the tumor extending into the left hepatic lobe still looks viable. So the patient went a second round of embolization. And again, the tumor seems to shrink, but there's still enhancing components anteriorly. And the question I have for you as you think about concepts behind treatment response is, how would you report this? What criteria would you use to report this and why? And is that helpful to the patient or to the interventionalist or to the community at large in terms of comparing response rates? So the outline of my talk is to go over modified RECIST, which has been around for over 10 years now, talk about the clinical gaps present in modified RECIST, go over the LI-RADS treatment response, and go very briefly through some case examples. So modified RECIST was a formal modification of RECIST that incorporated the idea of viable tumor based on enhancement, which was first proposed by the European Association for Study of Liver Disease, or EASL. And just as RECIST does, it identifies categories of response based on the degree of arterial enhancement that's residual after treatment. So with complete response, there's disappearance of all intratumoral arterial enhancement in all lesions. The lesions may still be measurable, but the enhancement on the arterial phase is gone. In partial response, there's a greater than 30% decrease in the sum of diameters of the target lesions. With progression of disease, there's a greater than 20% increase in the sum of diameters. And for stable disease, it's those that don't qualify for the other criteria. A target lesion by modified RECIST is very similar to RECIST. It needs to be accurately measured in at least one dimension and at least 1 centimeter in size. You should pick a lesion that's suitable for repeat measurement and that shows intratumoral arterial enhancement on CT or MRI. So the key here is you should see arterial enhancement. Non-target lesions include all other lesions. And the proposal by modified RECIST was not to measure the entire tumor, but just to measure the diameter of the largest enhancing component, avoiding intervening areas of necrosis. So if the lesion is heterogeneously necrotic, just pick the single largest area that's enhancing on the arterial phase to measure. So modified RECIST has had a lot of success. There's no question about it. And it's had a lot of success with local regional therapy and chemoembolization, or TACE in particular, which has become somewhat the dominant form of local regional therapy over the last 10 to 20 years. And by meta-analysis, a response by mRECIST seems to be able to predict survival. And that's important because ultimately you want to help patients to survive longer, not just to have a response that shows up on imaging. So you want to see a correlation between the two. Okay. So mRECIST has also been applied successfully to sorafenib therapy, which is a systemic therapy, and it's worth looking at certain survival curves. So the survival curve based on RECIST shows that there's a stratification in patients who have a complete response, which is actually only one patient out of this entire cohort, so 1 out of over 50. The majority had stable disease, so 42, and about 10 had progression of disease. By modified RECIST, however, you can see that there's a greater separation between those who had an objective response, so at least a partial response, than those who had stable disease and those that have progression of disease. And if you take the 42 who had stable disease by RECIST, then you can separate out by mRECIST those who had a favorable outcome from those that did not. So what does this tell us? This tells us that by looking at enhancement, you can tease out more patients who may get a clinical benefit from sorafenib. And sorafenib, when it was first proposed, it was accepted based on a prolongation of median survival of 3 months only. But there was a few patients that seemed to do much better. And by RECIST, that was considered to be around 2%. But by modified RECIST, we seem to be identifying a bigger subset of patients who may benefit from this therapy. And that's the important thing about thinking, it's an important concept when thinking about response criteria, in that it must be a surrogate for a gold standard of patient benefit, such as prolongation of survival, or at the very least, improvement in quality of life. If there's a dissociation between the response on imaging and the clinical benefit, then it doesn't matter. It's as if you say, well, you have a tumor that's in the liver and you resect it because you can, but not because it helps the patient. If you have a response on imaging, but it doesn't help the patient, then it's not worth measuring. Other considerations are that it should reflect the mechanism of drug action, and it should be reproducible in different hands. So modified RECIST reproducibility has been investigated by multiple different groups, and it shows very high inter-observer agreement, usually in the 0.6 to 0.9 range, which is considered substantial to excellent. The one exception was for radioembolization, when it went just below 0.6 to a moderate degree of agreement. And that's because with radioembolization, the effects of the radiotherapy can be a little bit more heterogeneous than with the other local regional therapies. And so it just becomes a bit more challenging to define the amount of necrosis or de-enhancement based on a single dimension, as you can see on the right. Some would argue, well, why stop at one dimension? That's just constraint that was developed by RECIST for ease of use. And you can push the limits and do volumetric imaging using software. And here's one study that looks at quantitative ESO percentage, where they applied this thresholding. Obviously, the more you can accurately demonstrate the percent of viable tumor, the more you can distinguish between clinical benefits. But this requires a lot of validation, and it's just not ready for prime time. So at this point, mRECIST, even though it's now over 10 years old, still remains dominant criteria for assessing patients after local regional therapy. But there are some challenges. And the challenge is that unlike systemic therapy, local regional therapies are applied over repeated sessions, sometimes sessions separated by months to years. And measuring the effectiveness of a local regional therapy when it's applied not continuously becomes very, very challenging. It's also challenging to use modified RECIST to communicate routine findings to the interventional radiologist. What exactly do you mean by partial response? How much of a partial response and where is the response in the liver? It also doesn't address uncertainty in progression of disease. Is the progression in the lesion you treated, or is it a new lesion elsewhere in the liver? And furthermore, it doesn't distinguish between local and distant progression, such as extrahepatic progression in the lungs or the bones. So if I do not apply modified RECIST during routine clinical practice, what is the alternative? And this is where the LI-RADS tumor response working group was faced with the task of asking, well, we have modified RECIST, it works, but we can't use it in clinical practice, so what can we do? What can we contribute in the context of LI-RADS to help individual radiologists dictate reports that are clinically meaningful and helpful? So back in 2014, we had this table that showed the LI-RADS treated observation on the far left, but it was kind of just left as a gray box to be further defined in the future. So there were certain challenges that we had to take into account. There were multiple stakeholders. Obviously, the diagnostic radiologist who's spending the effort and time to assess response, but also the referring clinicians, whether it is an interventionalist or a radiation oncologist. They want to know what's going on in their patients so they can plan the next steps, whether it is just imaging follow-up, repeated treatment, or alternative treatments, for example, systemic therapies when things are failing. We also had to challenge that there are an increasing number of local regional therapies every year. Developing new local regional therapy, from ablations to embolizations to radioembolizations, makes it challenging to develop a single response algorithm. We also have to fit into the context of existing guidelines, like OPTN if you were in the US. And there was a lack of standardized terminology beyond what modified RECIST proposed in terms of arterial phase hyperenhancement. So the aims of the LI-RADS response working group was to develop an algorithm that was applicable to all local regional therapies, regardless of which one, to define standardized terminology, to provide guidance on assessing viable tumor, and to incorporate an equivocal tumor response category. And all of this you can download from the manual. It was first published in 2017. The 2018 version of the manual is identical as far as treatment response is concerned. So at this point, this crowd is already very familiar with the diagnostic categories, going from green to red from increasing probability of HCC. And we now know that we can assign certain levels of specificity to each one of these categories. The corresponding treatment response categories are also labeled from green to red, red being viable, meaning that there's treated but probably or definitely viable disease in the HCC or tumor that you're investigating. So the criteria for each of these response categories are as follows. If there's no enhancement whatsoever, or there's a treatment-specific and expected enhancement pattern, which I'll give some examples of, then it's non-viable. If there's enhancement atypical for treatment-specific expected enhancement pattern, or not meeting the next criteria, then it is equivocal. And if it meets the criteria for viable, that is, it is nodular, mass-like, or thick irregular tissue in or along the treated lesion, it can have any of the following: arterial phase hyperenhancement, or washout appearance, or enhancement similar to pretreatment, just in case it doesn't have either of the two above. So note that unlike LI-RADS 5, you don't have to have both arterial phase hyperenhancement and washout. You can have either or. And it's really based on the morphology of the enhancement. Is it nodular, mass-like, or thick irregular tissue? In terms of measurements, we adopted the convention proposed by modified RECIST, which is to measure the single largest enhancing area. And if you had separate nodules of enhancement, just pick the single largest nodule to measure disease. Since LI-RADS treatment response has been published, there's been a few papers that looked at the reproducibility and the specificity of the different LI-RADS categories. And in multiple studies, you can see the kappa statistics are in the range of 0.5 to 0.9, which means that it's moderately to substantial to excellent in inter-observer agreement. And this is actually quite similar, maybe perhaps even slightly better than the LI-RADS diagnostic category. So even though the definition of what nodular and mass-like can mean different things to different people, the categories themselves are quite reproducible. When you have a lesion that undergoes ablation, such as in this example of a right hepatic metastasis at the right hepatic dome, the ablation zone is often quite large in comparison to the original treated tumor, and the ablation zone here is not enhancing, so this is a fairly straightforward case of a non-viable tumor. If you have an ablation zone that somehow misses the tumor, such as in this case, or covers the tumor, but there wasn't enough of a margin and there's a marginal recurrence, you can have the following scenario where on pre-contrast T1, there's a T1 hyperintense area of ablation, which represents coagulation necrosis, and the T1 hypointense nodular lesion of the margin, which enhances on arterial phase, and this is viable. Occasionally, there's still enhancement, but it's restricted to the rim and it's very thin and uniform, such as in this case. In the lower panels, you can see on arterial phase and portovenous phase, the rim does enhance, but it's an expected post-treatment enhancement pattern, so you can confidently call this non-viable. Here's another example of rim enhancement that's expected, in this case, after cryoablation of a tumor in the posterior right hepatic lobe. The evidence for LI-RADS is emerging, and it's a little bit hard to interpret the results from the different papers that have come out because they don't exactly report the same things in terms of sensitivity and specificity. But you can see here from these results a couple of trends. The viable category has a very high specificity or positive predictive value in the mid-80s to mid-90s range. So when we call something viable, we're often right that pathologically there's something left behind, that we're still detecting tumor that is alive. On the other hand, their accuracy or sensitivity as a whole is lower, and it seems to be lower on CT compared to MRI, which means that we don't always detect viable disease on pathology. And that's because imaging is nowhere near as sensitive as pathology when it comes to detecting microscopic disease. Now, the importance of detecting microscopic disease is another matter, because perhaps when we call something non-viable, that is a sufficient outcome that is relevant biologically for the patient. Notice that the LRTR non-viable category has a lower negative predictive value than the viable category has a positive predictive value. So how do you report this? How do you put this together and use it in clinical practice? We recommend reporting the post-treatment LI-RADS category and size, and then compare it to the pre-treatment category and size, and or if there's a biopsy confirmation of HCC, just call it HCC. So in a single line, you can actually communicate quite a bit. For example, LI-RADS treated viable, 2 centimeters, previously LI-RADS 5, 5.1 centimeter. This tells you that somebody treated a lesion that had met the LI-RADS criteria for HCC, LI-RADS 5. It was 5.1 centimeters, so beyond Milan criteria. And after treatment, there's still some disease, right? So you went from 5.1 to 2.0 centimeter. So there's a response, but there's still viable disease. But now you may be within Milan criteria for that patient, perhaps being considered for transplantation. On the next line, LI-RADS treated non-viable, previously LI-RADS 3, 1.0 centimeter. And the LI-RADS 3 can be a lesion that could have easily been an area of perfusion abnormality, but after, say, embolization of the lobe, it clearly appears non-enhancing, and so you kind of uncovered disease that was previously ambiguous. And LI-RADS treated equivocal, 10.2 centimeter, previously LI-RADS tumor in vein, 12.3 centimeter. Those with tumor in vein, those tumors with tumor in the portal vein can sometimes have atypical enhancement pattern, and after treatment can be harder to interpret. And that's an example of where equivocal may become in handy. So going back to the example I showed at the very beginning, the patient had 1 round of embolization. By modified RECIST, would have had a partial response. Had a second round of embolization, would still have had a partial response, but clearly based on the nodular enhancement along the margin, is still viable. And really that's the point of using LI-RADS, is to communicate to the interventionalist there's still some disease going on. Sometimes after embolization, you have very, very thin rim of enhancement that appears minimally nodular, just as an example here. And based on the emerging evidence after embolization and ablation, those that were called equivocal, which was used 5 to 10% of the time, were more often than not incompletely necrotic on path. So if you looked on pathology, those that were equivocal were about 4 to 5 times represented viable disease. So over time, as we learn more, we may start to think about getting rid of this category and just call it viable. But we're waiting for more evidence to emerge. Here's a case that's treated with radioembolization. And these are the ones that are most challenging, especially in the first 3 months when the embolization effects are still evolving. And this is something the Tumor Response Working Group is working on to provide more clarity in the next version or the next manual of LI-RADS. So you should use LI-RADS treatment response category in practice when you have single or limited multifocal HCC. When you have disease throughout the liver, numerous different foci, it may not be as practical to use individual categories for individual lesions. You can apply this to repeated treatments. For new lesions that occur elsewhere from the treated lobe, for example, use the diagnostic algorithm. So call those LI-RADS 1 through 5 as you would any other liver. And if you're comparing patient level response, for example, in retrospective research to compare effectiveness of different therapies, consider using mRECIST because that's what it's really designed for. LI-RADS treatment response is for individual lesions for routine clinical practice. In terms of future directions, are ancillary features useful for a LI-RADS treatment response algorithm, such as T2 weighted imaging or diffusion? There's some emerging evidence as well that using ancillary features may increase the sensitivity of LI-RADS treatment viable. For example, transitional phase washout when using gadolinium EOB-DTPA. And the goal here, or the impact here may be to reduce the use of the LRTR equivocal category when you see some barely enhancing nodularity, but it shows up on diffusion weighted imaging, for example. So in summary, LI-RADS treatment response algorithm addresses a clinical gap in reporting HCC treated by LRT. The viable category has a high specificity for viable disease after embolization and ablation, not including radioembolization. And the treatment response categories are used reproducibly, but further research is needed for those who perform radioembolization and external beam radiotherapy, and we're eagerly waiting those results to be published. These are the references. I'll just leave this on in case somebody wants to screenshot this. And thank you very much for your attention. So as Khaled introduced me, he said I was the former chair. The current chair is Dr. Mandarita Lala, who I'm pictured here with on the far right corner. And I'm happy to take questions, and feel free to email me your feedback, how you wish to see LI-RADS treatment response improve. We're always looking to crowdsource the intelligence of the entire radiology community. I'm ready to take any questions. Thank you.